I'm Sheilah Kast. I host an interview show on WYPR, the public radio affiliate in Baltimore. And so my perspective on pretty much all of life, but including mental health, tends to be through the prism of news. And certainly I'm sure many of you have a much deeper, more nuanced understanding of a lot of the issues, but if you just read headlines and you think of mental health in the same sentence with military, there's been a lot of bad news. There's been a lot of coverage of suicides, a lot of coverage of PTSD, a lot of coverage of traumatic brain injury. And you sort of think, well, that's an odd thing to talk about at such a exciting conference with so many frontiers. But there's a lot going on in military mental health. And we are very lucky to have three people who are each in the thick of a different frontier that is important in military mental health. So rather than introduce you to everybody all at once, I'm going to do this one at a time. And I'm going to first introduce Kate Sullivan, who is our clinician in this group. She has more than 15 years experience with hands-on cognitive experiences specializing in military traumatic brain injury. She is the director of the Brain Fitness Center at Walter Reed National Military Medical Center in Bethesda, Maryland. She has worked in cognitive rehabilitation with the U.S. military for more than 15 years. She designed and founded the Brain Fitness Center in 2009 to provide computer-based cognitive training as an adjunct to traditional rehabilitation treatment for service members and dependents. So far, the Brain Fitness Center has worked with more than 750 participants. It has expanded its services to include performance enhancement, mindfulness training, biofeedback. The Brain Fitness Center has 2 completed and 3 ongoing research protocols studying the feasibility and effectiveness of brain training programs within a military population. There's much more I could tell you, but I'd rather that she talk to you. Kate Sullivan.
Hello, how are you? Because I work at Walter Reed, that's the government, and I have to have just a few slides, especially because I have to have this, my disclaimer, that the views expressed in my presentation are those of myself and not reflect the official policy of the Department of Defense or U.S. government. So I have to have that slide. I have one other slide and then a short video I wanted to show you. It highlights the concept of the Brain Fitness Center is a little foreign to most, and when people want to come and get a tour, I say, well, it's just a room with some laptops that, that's getting loud.
You're fine. You're fine.
That's what it's supposed to sound like. So I'm going to show you this slide and then one quick video. Just to give you a background of why we even started a Brain Fitness Center. Back in around 2008, 2009, kind of the height of service members returning from Iraq and Afghanistan and staying at Walter Reed for a very long time, whether it's the amputee care or whether their medical boards were taking time that they should and also a little backlogged. But we felt that patients needed additional resources for cognitive stimulation. And our providers, our therapists, the occupational therapists, speech language pathologists, they needed more resources for their patients as well. So computer games, brain training programs, we said, well, let's try it. Let's see how our patients respond and track that over time and see if they like it. So we wanted to introduce that to the patients, but also develop protocols to follow them over time. So I'm just going to show you a video that allows you to see I think you could do it for me, thanks. Highlight some of the individuals I work with and a few patients that have come to the Brain Fitness Center.
So the Brain Fitness Center I think, represents a very exciting emerging area in rehabilitation.
He's had a lot of rehabilitation services here.
The area that we're particularly interested in is traumatic brain injury.
It's about 9 months after injury.
We started off with just 2 programs and have expanded to 7 programs. Although we were originally designed for the active duty service members coming back from the conflicts in Iraq and Afghanistan, we realized pretty quickly that there were many more individuals out there that needed something like this. And we've had over 450 patients now use the Brain Fitness Center.
I remember waking up in a construction ditch, and I don't remember the original accident, but I remember having to crawl out of it in order to get help. I think I crawled about 50 feet or so, and finally I came across somebody and they called an ambulance for me. I've been going to the Brain Fitness Center for about 2 months. It helps me to work on my memory, and there's a lot of different aspects to it. There's calculation, there's long-term memory, short-term memory, and many other things that you can do to improve your cognitive function. It's helped me really to remember faces, names, everything, even like my reading, and my math has gotten a lot better.
My unit was mobilized and deployed to Jordan on a mission. And while I was in Jordan, I was struck by a vehicle. I got involved in the Brain Fitness Center at the suggestion of my nurse case manager here at Walter Reed. It's really strange when you're 40 years old and you're used to being able to recall facts and do calculations and so forth, and then all of a sudden one little piece of that ability has somehow disappeared, or it's hidden for a while. And then over the course of several weeks of doing the program, suddenly, and I really mean suddenly, like from one session to the next, I came in and it seemed so much more easy to find those differences.
You're sharp today. You got it on the first try.
So along with the clinical care we're providing, we've been doing some scientific investigations around this. So we have protocols that we've been doing to randomize clinical trials to look at what works best for whom when.
Anecdotally, we hear so many stories about what these programs are doing for them and their lives. And we've heard everything from this has saved my marriage to I can finally go to the grocery store and remember things. And whether it's truly based on this program or just their overall empowerment of doing something for themselves and feeling good, we are seeing that it's working for our patients.
Using commercially available computer-based programs where we have outcomes pre and post, and actually about every 8 weeks we're tracking compliance and those outcome measures a long time, and then have different protocols associated with that. So
let me backtrack and ask: is the Brain Fitness Center entirely focused on traumatic brain injury, TBI?
No, originally designed for that, but also there were so many service members coming back from the wars who were saying something's not quite right, but they didn't fit the diagnosis for a traumatic brain injury. But they said my attention or concentration, whether it had to do with sleep, medication, it didn't matter to us. We said, go ahead, you can come in and use the Brain Fitness Center. We were at about 80%, 85% traumatic brain injury till about 2011. That started to change, and that's just the demographics of the hospital. We see a lot more psychological health, PTSD, and then some emerging populations. For instance, the individuals who are suffering from cancer-related cognitive changes, they call it chemo brain or chemo fog, and we've had a big uptick and are doing actually a research program with the Merthyr Cancer Center right now, seeing if using any of these brain training programs, even in the infusion room, whether getting their chemotherapy might be of any benefit.
And how do you, is there any way of describing to a range of levels of knowledge and understanding how you can fit together the activities of the Brain Fitness Center, many of which I guess are self-directed,
Yes.
how that fits together with therapy?
Right, so we never wanted this to be a standalone service. That the Brain Fitness Center and using computer games or brain training programs shouldn't be considered cognitive rehabilitation in and of itself. And so it's very important for us to make this part of the entire rehab package for anyone going through getting additional services or standard services. So we're part of the interdisciplinary rehabilitation teams, and we're constantly interacting with their psychologists, their traumatic brain injury case manager, and we're working towards a very specific goal. Most patients, when they come in, they kind of demo the programs to see which one fits for them. So what are their cognitive goals or long-term goals when it comes to academics or future plans with work. But sometimes a therapist, or let's say an audiologist, knows that we have one program that's specific to auditory processing. So they'll be referred for that specific program. Otherwise, we try to get them to find one that they believe will challenge them, but also they'll stick to for a longer term to reach some kind of benefits.
So the participant is actually very often choosing
Most often choosing.
what the course will be.
Yes.
And how long do they tend to stay with you?
On average, we have individuals coming about twice a week for 2 to 3 months. That's about our average. Some people come in 1 or 2 times. This is not for them. They're not gamers. They don't like computers, and this isn't for them, and that's fine. And others that have stayed with us for 2, almost 3 years, and hop from one program, they just spend a couple months, they go to another one. That's just something now part of their habit and their what they like they believe it helps them, and they feel better every day doing it, like going to the gym.
Like going to the gym?
Yeah.
How, you use the analogy of a gym. In what ways is it really very much like a gym in terms of how much of it is sort of repetitive, need to do it often to keep the skills fresh, and where does the gym analogy fall down?
It's the perfect analogy for most of our participants because they're young male service members. So they'll get it. Oh, if I exercise this part of my brain, it will get stronger. If I do so many reps over time, that will work. And it's also taking that gym analogy and the basics of neuroplasticity. And if you tell someone that there's a certain training threshold, if you go to the gym and you're always using 5-pound weights, or you get on the treadmill and you never actually push yourself, the incline never goes up, you never go any faster, you never sweat, why'd you go to the gym? So I said these computers are based to, in real time, challenge you at a specific training threshold. They give you a lot of reps over time, and when they feel if you've mastered a certain skill, you're going to get pushed. If you can now lift 5 pounds without any problem, it's going to push you to 7 pounds, 10 pounds, and keep going.
Same thing here.
Yes.
In deference to our time crunch, all 3 panelists have agreed to give sort of highlighted, compressed presentations, but we will have time for questions. I'm going to save a few minutes at the end, but if there's anyone who has a question now, this would be a good time to ask Kate something. If not, stow it away, hold it, and we'll get to it in a little bit. Let's move on to Dr. Corinna Lathan. She's co-founder and CEO of AnthroTronix, which is a biomedical product development company, a leader in mobile platform technology. AnthroTronix recently, a product which I'm not even sure how to pronounce, Corey. Dana. Oh, the TM that shows up in full case in my printout should be a little trademark symbol. Yeah. Dana, okay. It was recently approved by the FDA. It's an evidence-based mobile medical app intended to collect and display cognitive performance information for use in the evaluation of patient brain function. Dr. Lathan's diverse background includes extensive research, teaching, consulting in the areas of human performance engineering, medical device design, and assistive technology. She's been an associate professor of biomedical engineering at the Catholic University of America, my alma mater, and an adjunct associate professor of aerospace engineering at the University of Maryland, College Park. What should we know about what you do in terms of mental health in the military?
So my company, AnthroTronix, is an R&D company, and we've essentially been a DoD contractor for the past 15 years. So when the military had a problem about 5 years ago, they were very aware of our capabilities, and they came to us to help them solve this problem. And the problem is that when our men and women are deployed, they're exposed to conditions that cause combat fatigue and stress, depression, PTSD, insomnia, and many times blast injuries that can cause concussion. And the medics and the corpsmen don't really have very good tools to do quick and dirty neurological assessments. They have paper pencil tests. called the MACE, Military Acute Concussion Evaluation, that's very much like a mini mental. It's scored on 1 to 30. Guess what? Everyone gets a 30. And then a confounding problem was that a couple years before, there had been such a concussion crisis that the military had instituted cognitive assessment testing for concussion. The problem is, and it was a desktop concussion assessment, but the problem there is that cognitive assessments, as we all know, they're really brain thermometers. They can tell you there's something wrong with your brain, but they can't tell you why. So guess what? If you give a cognitive assessment test to deployed soldiers, say within 72 hours after a blast injury, how many of them do you think have cognitive impairment? A lot of them. Because if they didn't have a concussion, they probably have combat fatigue and stress. A certain high percentage of them have depression, PTSD. So it was a real problem. And so the concept of operations that they presented to us, they said we need to provide the medics and the corpsmen with a mobile tool that they can do a quick quantitative cognitive assessment to see if there's impairment shortly after an injury, but we also need a suite of tools that will not only do the cognitive assessment, but will also do some of the typical psychological screening tests, like a PHQ-9 or an insomnia severity index at the same time. And not just post-injury, if the corpsman or medic suspects that there's something wrong. And they don't want a lot of information, they just want a green, yellow, red. You know, is there a red flag here? We don't know why. Do we need to refer them to a higher level of care? So they asked us to develop this mobile tool, and they said, oh, by the way, it has to be FDA cleared. Okay, so just keep in mind this was also before there were guidelines on mobile medical apps, and there was also no predicate. Well, all that said, fast forward, at the end of last year, 2014, we delivered DANA, which before we went to the FDA stood for the Defense Automated Neurological Assessment Tool, but the FDA said you can't call it that, so it's now DANA, which is wisdom in Persian, so it all works out. And so we delivered the DANA platform. It's a software platform on any mobile device that can deliver cognitive and psychological assessment tools. And so we delivered that to the Army Medical Material Command last year, and it's now part of their product base.
So tell me in more detail what a corpsman learns from data. What is he going to walk away from that encounter knowing about the?
So it's literally a brain thermometer. It says, is there cognitive impairment? And if there's cognitive impairment, and you've also done some of the it depends which battery you do, but if you've done some of the standard is to do an insomnia severity index, a PHQ-9 for depression, a PCLM for PTSD, and a 5-minute, 7 or 8 minute, depending upon the test, cognitive assessment test. So it'll say you have cognitive impairment and no red flags on insomnia, depression, or PTSD. Now that's at the medic level. If you have someone at a higher care, they can pick and choose, just like any other cognitive assessment battery, they can pick and choose which psychological screens they want, how extensive a test they want to do. Someone who might know that certain tests focus on short-term memory or focus on other parts, specific parts of the brain.
Well, give us the short version of how you're trying to test dementia.
Well, I mean, the short story with dementia is that there's 44 million people worldwide with dementia. We all know it's an epidemic. By 2030, 75 million people with dementia, and 1 in 3 of us over 65 will die with dementia. So it's a huge epidemic, and the question is, what are some of the risk factors, and how do we test people's cognitive health before they have dementia? And so we've targeted an at-risk population, caregivers of dementia patients and chronic care patients. And so we've started looking at the brain health over time. Again, this concept of a brain thermometer. Our vision is that we care as much about our brain health as our body mass index. And just like we track your body mass index from the time you're born, we should be tracking your brain health. And so, and every time you walk into the doctor's office, they should take a brain vital, and you should be able to take a brain vital in your own home. So we're providing caregivers of dementia patients an app that actually tracks their brain health in a very user-friendly way, and also alongside of some key metrics that affect brain health, like sleep, stress, mood, depression. And so that's what we're doing now.
And is this an app you're developing for the military?
No, this is completely separate from the military.
This is for everyone. Okay.
Yeah, for everyone.
Same, Dr. Corinna Lathan, same thing. We'll have a few minutes later for questions, but if anybody has a question now, we could go straight to it. I don't see.
No, we don't. We don't. If you have a suggestion, I'll take it.
Well, how should we watch for its development? How should we watch for the news about it?
That's a good question. We have a website called the Health-eBrain Study. So it's a caregiver healthy brain study, Health-eBrain Study. And my Twitter's at C.Lathan, so keep an eye there. But the website, the Healthy Brain Study website, should find it.
Great.
And I'll post it on the Twitter feed.
Great. Thank you. Justin Sanchez joined DARPA as a program manager just 2 years ago to explore neurotechnology, brain science, and systems neurobiology. I'm not sure I understand any of those, but you're going to make it clear. Before he came to DARPA in 2013, Dr. Sanchez was Associate Professor of Biomedical Engineering and Neuroscience at the University of Miami, a faculty member of the Miami Project to Cure Paralysis. He directed the Neuroprosthetics Research Group, where he oversaw development of neural interface medical treatments and neurotechnology for treating paralysis and stroke, and for deep brain stimulation for movement disorders, Tourette syndrome, obsessive compulsive disorder. Dr. Sanchez has developed new methods for signal analysis and processing techniques for studying the unknown aspects of neural coding and functional neurophysiology. Tell us what this means for people in the military. What are you doing?
Yeah, absolutely. So first, thanks for the invite to be on this panel. It's a pleasure to share the stage with all of you. So just to start off, so I come from DARPA, okay? And for those of you who don't know who DARPA is, we're a funding agency, and our mission is to deliver innovative, groundbreaking kinds of technologies for issues of national security. And without a doubt, the brain and neurotechnology is very much on the landscape of national security for our future. When I came to the agency, we were just beginning to break into a realm of neurotechnology where we could develop direct interfaces to the brain, okay, so direct electrodes in the brain to sense what the brain is doing, and using that information in order to do work in the world. And the first problem that we really focus on was restoring movement and sensation to people who have lost that brain function in service of the nation. And many of you may have seen some of these videos from DARPA of our work on this problem, where we've had people that are living with paralysis with direct brain interfaces, thinking about controlling a prosthetic limb and having that prosthetic limb move just based upon their thoughts. It's remarkable, it's amazing. People said, you would never be able to do something like this. What's fascinating about those first few steps from the agency, and the agency's really pushed to leapfrog technology in this area, is that it helped to spark our next work in the area of neuropsychiatric illness and brain health. And that's what I'm here really to tell you about today. Those first few demonstrations of direct interfaces to the brain, the potential of them, helped us to ask that next question. When we say 10% of the 22 million Americans that are living, or veterans living with neuropsychiatric illness are going to their clinicians and are seeking therapy, we said, what kind of direct brain interfaces can we develop for tomorrow that will enable us to have very precise understanding of what the subnetworks of the brain are doing with respect to those diseases and those disorders? And how can we develop real-time closed-loop technologies that interpret that information, guide clinicians on how to give very precise stimulation feedback directly to those neurons of the brain in order to help remedy those problems. So that's the core of the issue here. Interfacing directly with the brain, sensing what's either going right or what's going wrong, using engineering and neuroscience kinds of concepts in order to guide how we precisely deliver stimulation back to the brain. And what's amazing about this challenge that we're going after here is that we know almost all of the neurosurgeons that are working in this space that are out there. We went to them and said, do you have the technology available today, let's say, to interface with 3, 4, 5 different sub-networks of the brain that are involved in mental health or neuropsychiatric illness? Can you get the information out of those centers, and can you deliver that therapy? And they all came back and said no. All right? And whenever we hear this kind of no, and this is impossible to do something like this, DARPA steps up and says, okay, we'll take on that challenge. And we've put huge resources back into the community, not only the clinical community, but also the engineering community, to develop these next generation kinds of fully implantable devices that can sense these signals from the brain in real time, can process that information, and can deliver that precision therapy back to the brain. Now, how far along are we?
That was my question, yes.
How far along are we in doing all of this? So the other very important piece of information here is that all of the programs that I manage are in support of President Obama's BRAIN initiative. Okay? And so in 2013, President Obama went out before the world and said, brain sciences and neurotechnology are a strategic area for us to move into. And the federal agencies are going to come together. So DARPA, NIH, NSF, IARPA are all going to come together in order to help move the ball forward in this area. So the programs that I've started, one in neuropsychiatric illness and one in the area of restoring memory using these innovative neurotechnologies, have been underway for 1 year. Okay, so just in 1 year of work, we have already developed prototype devices that can do the things that I just mentioned to you: sense from the brain, process that information in real time, and stimulate the brain in order to produce a therapeutic effect. We're already in human subjects, and we're already studying indications like anxiety, so intractable anxiety. We have shown in a handful of subjects that using this approach, this closed-loop approach, that we can have an anxiolytic effect for anxiety. And again, amazing. That we
let me
can
make
do this
sure
in
I'm
1 year.
understanding this.
Yeah.
You're saying that within a year, I'm sure, building on other research, but in a year, you have developed you are testing an implant that helps ease the anxiety of people with chronic anxiety.
Yeah, exactly. So this really illustrates the DARPA approach to doing science and technology development. We can put the bar extremely high and say, look, we're going to go after this extremely difficult challenge. We can find the best people in the field in order to go after that challenge, and we can provide significant resources to them so that they can accelerate their research in order to do some of the things that we're doing today. So again, we have very prototype kinds of technologies, but nevertheless, those technologies are helping to deliver more knowledge, more information, and enabling technologies in order for us to dig deeper into these very specific areas. So this is in the area of anxiety. We're seeing great accomplishments thus far. We're also seeing great accomplishments in the area of memory restoration. So we have these same kind of implantable kinds of devices that we're prototyping today. Again, these are not ready for mass markets or anything like that. We're just proving the technology. But we're already showing that with specific neural interfaces into the networks of the brain that are involved in memory formation and recall, we can restore memory 25% or more when we do behavioral tests and can detect that a person's memory is not going to be good. So if you kind of think about this in the context of traumatic brain injury, if somebody presents to the clinic and says, look, I have a traumatic brain injury and I'm seeking alternative kinds of therapies, the vision is develop a direct neural interface that can pinpoint those networks that are not functioning properly, interpret why those networks of the brain are not functioning properly, and then deliver a direct stimulation to those networks to facilitate their ability to form and recall memories again. And again, in just 1 year of work, we're seeing some preliminary evidence that we can do this.
So one of the things that I'm struggling to, I find myself thinking about these three brains next to me. What is going through your brains as you hear each other talk?
I think he's going to put me out of business.
No.
Which is good, right?
I knew that you were going to say this, but let me give a contrasting perspective. I was actually exhilarated when I heard the work that was going on with the other two panelists here, because one of our core concepts that we're building in all of this work is that it's not only the brain and the function of the individual neurons in the brain that's really important here, but it's coupling all of that with training and therapy, as well as very specific metrics and measurements of behavior, not only to that individual, but also the environment that's around them. So what's built into all of the programs that that I'm describing today are the incorporation of all of these aspects. We see the combined effect is what's going to get us through the hurdles and have that really profound change in people's lives. So I don't see these as exclusive kinds of approaches. I see them as an integrative approach to dealing with these complex disorders.
But if you know the circuits involved, is that something that's going to help your clinicians do a better job of figuring out what shape of games, what kinds of games, how much to use? I keep saying games, it's not just games, I know, but is that additive from your perspective?
Oh, absolutely. Any of the science and technology that comes out of that is almost always applicable at a basic level to help us understand. And it's actually not even just the clinicians, but probably those neuroscientists that are developing these brain training programs and designing them to certain ways. And the more they learn, it's going to apply to what products and programs can come through us to the patients. Absolutely.
And think about it this way. Let's say you had access to this real-time information that's coming out of the brain, and you could tailor the kinds of training that you were giving. Maybe you could reinforce the right networks at the right time in order to get the maximal behavioral effect that you're ultimately looking for. And again, that's the potential that we see in all of this together.
Tell me again, you said it, but I don't think I held on to it. There are 5 areas, 5 kinds of brain activity you're looking at, is that right?
So let's say 5 centers. So for example, let's take a memory for example, right? Again, this is a complex function of the brain. It may involve the hippocampus, it may involve the prefrontal cortex, it may involve the temporal cortex. Today, we don't have the ability to tap into all of those areas simultaneously. Again, read out how those individual neurons are involved in the formation and recall of memory, and then interpret that and deliver the therapy ultimately back to those neurons. That's the kind of enabling technology that we're trying to develop. Right now, the tools that we have access to us right now are things like fMRI or MEG or those kinds of technologies. We're trying to develop these technologies that people could ultimately take home with them and that provide high resolution kinds of information and insight into the brain.
I hear you talk about this, and I think as a journalist I should be asking you whether the NSA is looking over your shoulder about getting into my brain, but you probably wouldn't answer that even if you could. So we have just a few minutes left, and I've been asking all the questions. Surely there must be some other people in this room who are as intrigued by all this as I am and have questions. And I'm just not seeing any hands yet. Nobody wants to be part of this conversation?
Oh, I got someone.
Hi, great stuff. The pertinent question is, are your assessments invasive or non-invasive?
Yeah.
Or a combination?
Yeah, fantastic question. So today...
Could everyone hear the question?
So the question is, are the measurements invasive or are they non-invasive? So today, the technologies that we are developing, they are invasive. They require a brain surgery, okay? And we recognize this, and this is the starting point for getting access to the circuits that we know are involved in this. At the same time, though, again, DARPA's thinking way out into the future. We always ask the question, if we want to have the biggest impact for our service members, how do we develop technologies that are either less invasive, minimally invasive, or even non-invasive? And the tough part about that challenge, again, those technologies, they don't exist. Right. I mean, that's a tremendous engineering and physics problem that one has to overcome. And we're really looking close at that and trying to develop those technologies.
Well, DARPA's so advanced, I just sort of get a test as to how far you went.
Right. Yeah, so it's amazing, and I'm glad you asked that question, because we put a challenge out to the community. Again, we scoured the world. We say, look, does anybody know how to do this? And we got a lot of information back, but we did not see that 100% solution yet that could get the kind of resolution and time and in space that we know we need in order to solve this. So it's still something that we're working on.
I had a question about the...
Could you get a little closer to the mic?
You mentioned, Ms. Sullivan, that the kind of brain training that you use in the Brain Fitness Center is publicly available. Mm-hmm. So I'm curious, how did clinicians out in the field find out what psychologists are offering these, or which tools you're using there that we might be able to use in our offices?
Yeah, everything we're using besides two are commercially available. I mean, it's the types of things like lumosity that you hear on the radio all the time. That's just like an example of a commercially available program. You can go on the internet or download something. There's others that have to actually have like a neuropsychologist or psychologist following them. For instance, like CogMed is working memory, very specific training that they want more neuropsych testing to be done with it. So I'm happy to tell you everything we're using without endorsing anything from the government. But yeah, we're also using some biofeedback and one neurofeedback program within a research protocol. And an environment, I don't know if you saw a picture of the egg. Actually, it's called an orb, where they can go in and shut the door and do their training in there as opposed to the actual computer.
And I know there's a research component of what you're doing. Are you keeping track of results of those, of these different
So we're tracking all of our clinical patients that consent to have all of their demographics, the results of their self-report questionnaires. We use a very kind of short objective cognitive assessments that is computer-based as well. And then we track them over time to see just compliance. We look back and say those who choose program number A seem to stay longer than those that choose B. Those get better in one certain area if they're looking at one program or the other over time. Plus, there's a couple research grants specific to looking at, we have one randomized controlled study that has a placebo-type game and one real game that's more developed for traumatic brain injury specific. Most of these commercial available programs were not designed for our population. This one program that we're studying now would have more like executive functioning type skills that we're looking at.
Dr. Sanchez, this morning Dr. Jin was talking about the Brain Treatment Center in California, and he was talking about the MRT being able to stimulate the brain and impact the frequency of the brain so it would work more effectively. And that's non-invasive. How is that different than yours, where you do the implant to be able to do the same kind of stimulation to change the brain functioning?
Yeah, also a great question. So the majority of the concepts that we've talked about thus far on the panel has been about reading out information from the brain, okay? And to read out the information, again, that's the real difficult side of this, right? Again, it's a biophysics problem of being able to get close enough to those neurons in order to sense the minute signals that are coming out of them. Now, the flip side of the story is, how do you modulate the brain, right, using stimulation in order to get a therapeutic kind of an effect? And there are some preliminary indications out there that using non-invasive stimulation, that you can do these kinds of things. And we have a few small investments in this space, especially in the area of memory formation and recall, that we're trying to understand how those non-invasive stimulations actually affect the underlying neurons that are involved in those processes. And again, it's amazing from a scientific perspective that there's not a whole lot known about the direct correlation between a non-invasive stimulation and actually how those neurons change their firing. So we're first trying to figure out that relationship, and then if we do get some traction in that space, then I think that there really is an avenue to move forward in that direction. And again, if people are already making some advances there, fantastic. We would look to try to build upon some of those early examples.
Thank you.
Yeah.
Other questions? Well, in deference to our time crunch, and since our panelists are going to be with us, you can catch them in the hallway, I think this is a good time to thank them. Kate Sullivan, Director of the Brain Fitness Center at Walter Reed, Justin Sanchez of DARPA, and Dr. Corinna Lathan, co-founder and CEO of AnthroTronix. Thank you so much. Thanks.
Thank you.